Today's lecture is on mandibular trauma, things that you should know. This is directed mostly toward residents, but it's really for all of us. I wrote a chapter in the resident manual for trauma, and chapter 5 is on mandibular trauma. And I'm going to reference quite a bit of this, and if you don't have access to it, the PDF is still online. It's been out there for a few years. We recommend it for our residents at the University of Colorado. And this is a nice thing to have because it covers the entire face and it's very up to date. So if you do miss this lecture, you can certainly pick up on a lot of what I'm saying today on this article. The mandible isn't alone. It certainly functions with the rest of the face, but today we're going to kind of isolate it. We're going to take it, we're going to isolate it, but we're not going to quarantine it. We're going to take a good look at what happens to the mandible, the different regions, and how we treat them when we do treat them separately. They're all unique in their fracture forms, whether it's condyle, coronoid, angle, body, ramus, symphyseal or parasymphyseal, alveolus. These fractures are all treated in their own unique way. So we do articulate with the maxilla. Generally in maxillofacial trauma, these two organs are united. Generally, if both fractured, the mandible is first, followed by the maxilla. If the maxilla is intact, we use that for our occlusion, and we'll talk about that in just a bit. The patient that I'm going to describe here has two fractures. One is behind the canine, I believe here, so this is almost a body fracture, but it's a parasymphyseal because I can't tell exactly if that's the canine or not, but and then there's an angle fracture here. So these are CT scans. I didn't have a 3D that looked good, but the you can see that the left angle is fractured and displaced. The infraalveolar nerve canal is displaced and the patient is numb on that lip. But the thing is we have to look at what the lower border is doing here in this case, and you can see that it is disrupted, and this is very hard to treat with a simple treatment of the upper border. So we have a lower border problem and an upper border problem. And then anteriorly, we have a fracture that's separate and certainly has to be treated separately. Excuse me. So under treatment for this patient, we fix the upper border or the external oblique ridge with a champy plate and then an small open procedure for the inferior border with wire osteosynthesis. We utilized IMF screws or MMF screws for our occlusion and to help keep the wounds stable while the patient was healing. The right-sided parasymphyseal area was treated with a tension band and a heavier plate on the inferior border. So this area is torqued differently than this area. The muscles that are pulling these various regions in different ways, so they actually all have to be treated separately. Here's a patient that has a month-old anterior jaw fracture. She's 72 years old and fell and broke her anterior mandible. And she's got an infected tooth and plenty of hardware, actually nice dental treatment to the teeth. And this area is abscess. So she has an abscess that is draining at the chin, and now how do we treat that? Is that pretty standard and straightforward treatment? No, it's not. She's got an infected jaw that's displaced, and she can't eat. So the plan here is to do an open approach and look at this infected tooth that's hooked to a bridge and that is causing an abscess in this area. My question comes to how do we do this type of fixation? And you use a plate, two plates like you would with a tension band and inferior plate, no plate at all, wire fixation, bone graft, hyperbaric oxygen. These are a variety of ways to look at this. I chose a figure of 8 wire osteosynthesis here, removed the tooth and closed her and put her on antibiotics. The tooth is missing. She was able to keep her bridge, and the wound healed very nicely 2 months later. So under these circumstances, we're using osteosynthesis using wires, strictly with airlick arch bars and an inferior border wire. So this is not rigid fixation, and we'll talk about that. Okay, mandibular anatomy is very important because it's a mobile bone. It has a joint that allows it to articulate with the rest of the face. The nerves in this area are the trigeminal, which is both motor and sensory to the mandible, but we have to realize too that the neck and head have a variety of other functioning structures that can cause pain in the temporal mandibular joint, muscle pain in the neck, head and face pain, and can radiate actually into the sinuses, and there is nerve generated pain from the dura through migraine type association, and so this is a very complex area indeed, and it's all regulated through the trigeminal nucleus caudalis. It's also called the subnucleus caudalis, and it's this small nucleus here that actually is fairly long that runs this entire area. Even the periodontal ligament spaces that are very important in neurogeneration for sensation of chewing are regulated certainly by this nucleus. And you notice when you bite on a small BB or something that's in a piece of meat that's abnormal, it causes a pretty significant reaction. And all this is important to restore during the treatment of a trauma patient. Vascular supply is extremely important because certainly damage to the bones in the face can create hematomas and airway compromise. And the internal maxillary artery is seen coursing up from the external carotid through this space. It's in the masticator area. It actually goes between the internal pterygoid and the lateral pterygoid muscle, and then progresses up into the pterygopalatine fossa. And, as far as mandibular bone goes, the adult bone is seen here with adult dentition, but it wasn't always that way. It started at birth with just very basilar bone. This is the mental foramen, and the condyle is very short here. As the child ages, development of the primary dentition. You can see the alveolar bone here now above the mental foramen and the extension of the vertical portion of the mandible. The adult vertical portion is much larger, and the dentition is quite a bit different. The root systems are totally different in anatomy and strength, and allow us to be more aggressive in treatment of fractures. The older mandible, again, has lost its alveolar bone because it's lost teeth, and the teeth and the alveolar bone are in a symbiotic relationship. Without teeth, the bone goes away, and then the mandible gets very thin and hypertrophic. And each one of these mandibles are treated differently in the trauma patient. Muscles of mastication, the closing muscles are the masseter, the internal pterygoid, and temporalis. So how do we open the mandible? How does the jaw open when you take a big bite? The question here is what muscles? And the answer is the external pterygoid and the digastrics. Okay, so it's not just the external pterygoid here that opens the jaw. It's the primary opener of the jaw. But if you look at these depressors of the mandible, the digastric, the mylohyoid, the infrahyoid, and the suprahyoid musculature actually also help to open the jaw. So you wonder sometimes when you have a condyle fracture how a patient can open his jaw when the muscles aren't attached. And some of the answer is in the infrahyoid and suprahyoid musculature. Okay, so the primary openers are going to be the lateral pterygoid and the suprahyoids, which I just mentioned, and then some of the infrahyoid that stabilize the hyoid bone. Elevation is, again, through these three major muscles, and they're paired muscles. But the jaw has many different movements: protrusion, retrusion, and side-to-side grinding movement. And they all are affected by certain fibers of each of these muscles that actually work independently. The outer portion of the mandible is mostly masseter attachment, a very strong muscle with some temporalis at the cornoid. The inner part of the mandible has temporalis in a much larger amount medially, the external pterygoid at the triangular fossa, and the internal pterygoid opposite of the masseter muscle, creating a pterygomasseteric sling. And you can see that sling here. This is very important too on the direction of pull and the extraction of fractures. Okay. The medial pterygoid is attached to the lateral pterygoid plate on the medial surface. The external pterygoid is attached to the external portion of that plate. The medial pterygoid plate, all part of the greater wing of the sphenoid, does not have a muscular attachment. This medial pterygoid actually has two heads, and one of it attaches toward the tuberosity of the maxilla and part of the palatine bone. All of the muscles of mastication are run by the trigeminal motor branch. And here's a picture of the sensory and lingual distribution here. So the sensory would be the infraalveolar nerve, and then the lingual nerve supplies tongue and mucosa of the mouth, and then the mylohyoid nerve here. So this is kind of in this area that we treat fairly frequently with ramus fractures. Okay. Favorable and non-favorable. Favorable fractures we generally treat with maxillomandibular fixation because muscle will actually close a fracture. This is in a very two-dimensional plane that we're looking at this fracture. This is an unfavorable fracture where the masseter and pterygomasseteric sling will distract it. Unfortunately, it isn't this simple, and many of the issues have to do with the different pulls of these retractors and protrusors and elevators and depressors. So the pulls are in many different directions. The condyle is being pulled medially and anteriorly. Medial pterygoids are pulling in a plane medially here and not just up and down. And you can see the same thing with the mylohyoid and genioglossus distracting segments of the mandible. And these all have to be taken into account when the fracture is evaluated. Very important is the temporomandibular joint in all of this. The temporomandibular joint has an articular disc that's biconcave, and it's attached to the superior head of the lateral pterygoid, where the inferior head is a much larger muscle, and it's attached to the triangular fossa here at the condyle. It's important to note that tearing the retrodiscal tissues can pull the articular disc anteriorly, and relocation into that disc causes clicking in the jaw. So we have a diarthrodial joint here with two muscles attached in these two different spots. As far as moving forward with trauma, the indication that you do have a fracture Has a lot to do with the symptoms of the patient. So there's going to be subjective and objective, and they have pain, open, usually a bite deformity of some kind, numbness, bleeding, swelling, and dyspnea. The signs are pain, deformity, tooth and fragment hypermobility, bleeding, hematoma, swelling, crepitus, restricted function, and sensory disturbances. It's very important that we address hematoma and the fact that the airway is of major concern. Fractures, certainly in the anterior segment here, can displace the tongue. Large fractures of the mandible that include the inferior alveolar artery can produce airway compromise. This patient was intubated and had no airway due to enormous swelling after fracture. So these things have to be observed and certainly treated when needed. Classification of fractures are generally by anatomy. We classify them as symphyseal, parasymphyseal, body, angle, ramus, alveolar, condylar, and coronoid. And they're shown here with the variety of different incidences. So the most common is the condyle and the angle. These are the areas that are affected most frequently. The terminology for any bone fracture, but specifically the mandible, can be used here in this table in chapter 5 regarding compound and open. Anytime erupted teeth are involved, it's considered an open fracture. Simple fractures are not exposed to oral secretions, and they usually do not involve tooth-bearing areas. The favorable fracture and unfavorable we just talked about. Comminuted fracture are usually crushed or multiple fragments. The complex fractures usually involve those bones and adjacent soft tissues. And then the variety of other fractures here, including pathologic fractures when we had a patient with an infection or a tumor, and those are all treated according to the origin. The mandible condyle is the most common site of fractures, up to 30% of the time, and it's often in combination with parasymphyseal or other fractures. The condylar head, neck, and subcondylar areas are evaluated separately. Certainly, treatment of the head and neck are difficult. The subcondylar fractures are fractures that go below the coronoid notch down posteriorly, as this is indicated. These are ones that we generally treat. These can be treated by open approach, but put at risk the facial nerve. Okay. So the mandible angle is this angle here, level with the alveolar ridge, and this pie-shaped area is this distal to the third molar. So this is the entire angle here. This is the second most common site, up to 25% of the time. Here's a patient that had a wisdom tooth removed and was bumped on the jaw and fractured through the left angle. And we're just going to go through this film and give you a little bit of an idea what the fracture looks like. And this angle, this view here, a sagittal view, shows how weak the bone is through this area. So the wisdom teeth is one area why, one reason why we see angle fractures, and the bone here is clearly fractured and a bit comminuted. So how do we treat that? So that's an interesting way is with wire osteosynthesis again. It was able to bring the fracture together very nicely. The loss of bone because of the extraction of the third molar and the surgical extraction of the third molar created such a large bony defect that wire was the only way to bring it together. And then we kept the patient. It was a good patient. We kept him in IMF wire fixation through MMF screws. And you can see the wire is broken here, and I think he came in for a wire check. But this was treated very nicely with just a simple wire. The fractures of the mandibular body are generally distal to the symphysis. The symphysis is behind the canine here, so this is a body fracture through here. The bodies are a little bit more difficult to access, to treat, and we're going to talk just a little bit about access in just a second. So next is symphyseal and parasymphyseal. This is the symphysis region. It's behind the canine. The fractures right in the midline are called symphyseal fractures, and anything that's paramidline in front of the bicuspid are going to be called parasymphyseal. Again, fractures in this area that are bilateral can cause airway compromise. An interesting fracture in that chapter that I added was the way a mandible can flail here due to muscle pull. And you can see that you can fix the anterior portion of this and feel like you've done a good job, but the flail part is still open, and so this really needs to be closed in order for proper function of the mandible and occlusion. So that's just one of the things that we have to watch for in the anterior area. Fractures of the ramus are rare, 2 to 4%, and many times can be treated more simply with IMF screws or soft diet. They're covered completely with muscle on the medial and lateral side and have a good blood supply and rarely have any issues in healing. The coronoid is very rare, and it's usually associated with fractures of the zygoma. Okay. Dental alveolar fractures are fractures in this bone where the segments of teeth are loose. Generally, it's anterior. Here's a patient that has an ankle fracture, and this segment is loose. So using acrylic acid etch composite and simple wire, these teeth were secured. They were not wired into the Ehrlich arch bars due to their mobility, and the patient had a good outcome. So alveolar fractures can be treated with your dental colleague or oral surgery colleagues utilizing this method, and it's very easy to use. You just need a light and some of the material and a piece of wire, and then you refer them back to the dental people to help to remove this in 6 weeks. Okay, diagnostic evaluations. The traumatized patient has to have a full body assessment, and that is done with your trauma colleagues, history, head and neck exam, oral examination, and I want to focus a little bit on occlusion. The occlusal plane is different in the upper arch. These teeth are bigger, and these teeth on the mandible are smaller. That being said, you can see that this upper tooth actually lands here on this buccal groove. So this is considered a class 1 occlusion. This was set up years ago by Dr. Engel for a class 1 occlusion, showing that buccal cusp laid right here in that groove. And if the teeth are moved back, the mandibular teeth are, the jaw is retrusive. It is showing here that upper cusp is being moved farther forward and vice versa in a prognatic bite. So when you evaluate a patient, it's important to kind of see where they are. I find it much more important to look at maximum intercuspation. People don't have teeth that look this good, and you have to understand that maximally intercuspating is where most patients are, and they have to hit on both sides of their mouth. There are a variety of malocclusions we're going to discuss, but I like to describe their bite as maximally touching as many teeth as possible. And I think that's a good rule of thumb, especially you know, when you're repairing the occlusion. It's often difficult to get anywhere close to this, and this is mostly from the orthodontic literature where everything is supposed to be perfect. Wear facets are something that you can interdigitate upper and lower teeth to, and when a tooth doesn't properly line up, you'll develop these flat planes, and then you can see them here, and they usually have a little dimple in the middle, but these are wear areas, and this is where teeth can come together nicely. Part of the way the front of the teeth come together in the anterior evaluation, when you talk about overjet and overbite, the horizontal overlap is jet, where they jet out, and then the vertical, where this deep bite is called an overbite, and you can see these too, and people will naturally have a variety of these. So this is a patient with a significant overjet. This is a patient with a significant overbite. This is a class 3 malocclusion. This is a class 2 malocclusion. And you can actually look at the malocclusion with the canine relationship too if you've lost molars. I'm not going to go into that. Occlusal evaluation is a big part of what we're doing in trauma, but there can be skeletal malformations with large and small jaws, both upper and lower, hypoplastic maxillas, and I'm not going to go too far into that, but this malocclusion is evaluated through cephalometric analysis. The dental occlusion does change throughout life. If you lose a tooth, you can have a mesial inclination of the molars, and they all attempt to move forward to take up the little spaces between teeth, and that's just a natural progression. Teeth also super erupt. If you lose a tooth, it can erupt further out. Here's the patient with teeth not knowing what they're supposed to be doing, and they go in a lot of different directions, and they are influenced by musculature of the buccal muscle and tongue. Okay, this is an anterior open bite, probably from thumb sucking as a child. It can also be seen in bilateral mandible fractures. This is a midline that's off. This is a right-sided crossbite. And also a left-sided crossbite. So you'll see this, and you'll want to fit these teeth together the very best you can. This is a nice bite. Everything looks normal here. And this is a class 3 malocclusion with the lower jaw further forward. So this cusp should be in that groove. Okay. Mesial and distal instead of medial and distal is the nomenclature under occlusal evaluation circumstances. We talk about the different morphology of the teeth being facial orientation or lingual orientation or buccal. Mesial is on the front part of the tooth, distal is on the back. The top of the tooth is occlusal. The top of incisor teeth are called incisal edge. A lot of fancy terms. Show the teeth toward the midline are mesial. Anything is distal. Okay. Occlusion has to do with the way the teeth come together. These cusps here, and they're marked along this surface, actually have to go inside the fossas of the lower teeth. And occlusion is the science of making sure that all these are hitting correctly. When the teeth all hit together perfectly, it's called centric occlusion. When the condyle is nicely in the fossa and the teeth hit together, it's called a centric relation. So under this picture, you can see that the teeth are not coming together, but the condyle is nicely situated. And you'll see that a lot. You'll try to be placing the teeth together and the condyles aren't exactly where they need to be. It's more important to get the occlusion together under the circumstances that this patient has a centric relation, which is intact, but their centric occlusion is not. And this patient has the bite perfect, but the condyle is not where it's supposed to be. So he has centric occlusion, but he is not in centric relation. And to have both together is where you really want to be. And many times that's what the reconstructive surgeon spends time trying to figure out as he repairs the jaw. So vertical dimension is another thing to be considered or to consider under these circumstances. And that's actually a distance between the chin and the nose. This patient has had a dental facelift, and he has had restoration of teeth that were missing that would allow his face to be full again, the muscles to be at the correct lengths, and that sort of thing. And you can see that the chin is lower because he had lost teeth and the chin had collapsed. And sometimes you get the commissures here will actually fissure when loss of vertical dimension. So we are technically restoring vertical dimension under these circumstances of repair of the mandible. Teeth numbering through the adults are 1 through 32. We have 32 adult teeth. Pediatric teeth are numbered A through T. And it always starts in the upper right, and then we march around to the lower right, same here in the adult dentition. So these are letters, these are numbers. Okay, imaging studies, number 1 and 2 are CT scan and Panorex. You can see here how valuable CT scans are, 3D, especially CT scans, and some of these are easier to convert now with their own internal algorithms on the PACS systems. The follow-up with the Panorex is very nice. Here's a patient who is being followed with this fracture. You can see that patient has superior border wire and arch bars, and you can actually see how this wound is healing with the radiodensity in the fracture site. So these are great for follow-up with low amounts of radiation. Mandible series MRIs, occlusal views, and periapical radiographs are rarely indicated. The surgical management, we're going to talk about that a little bit, especially access. We're not going to get into a lot of theory, but how do you approach these? And certainly there's more in that chapter if you want to dig into it. But I want to briefly review this and then just talk about some complication management. So indications for open or closed surgery are not absolute. Many of them are relative. The indications for closed reduction is simple fractures that are non-displaced that are favorable. Many pediatric fractures fall into this category simply because the developing teeth can be damaged. Grossly comminuted fractures are generally closed with closed reduction, simply because they have issues with periosteal bone stripping of fragments. And we've seen many mandibles stripped of bone fragments and when we could have used them. So it's a good idea too, under grossly comminuted fractures, to bring things together and allow them to start to heal before stripping small bone fragments and losing those, requiring pre-flaps and things like that. The coronoid fractures generally are closed, and adult condyle fractures, depending on where they are, we talked about this earlier, can be treated closed. Contraindications: if the patient has pulmonary reserve issues, asthma, severe COPD, they have seizures, if they're psych patients that would do miserably under MMF, I would not close these people, I would certainly consider open treatment. People with severe nausea and eating disorders would also benefit from internal fixation. Indications for open reduction, generally displaced and unfavorable fractures, as we showed earlier. Atrophic mandibles with minimal cancellous bone and poor osteogenesis, and they generally do better with open reduction with, I'll talk about it in a minute, with internal fixation. Complex fractures that are not easily treated should be done open, and condylar fractures, we will discuss both of those. There are absolute and relative contraindication to opening the condyle to treat, and that is a fairly old classification, but it still rings fairly true, that absolutely if a condyle is displaced into the middle cranial fossa, if you cannot get the occlusion together, it's important to open. And if the condyle is sticking out laterally and dislocated, that's another indication. And then a contaminated wound, it would have to be opened and cleaned and treated. And those are really the absolute, the relative indications are seen here, and they're available in that chapter. The mandible fractures involving teeth are considered open and should be treated usually within 24 hours of surgery. And many places don't look at these fractures as being urgent. We feel that there are higher incidents of complications beyond 24 hours. So timing is very essential in managing these. Exposure options for treatment under closed reductions are all transoral. The wire synthesis is done through arch bars. We use 24 gauge on adults and 26 on children. And sometimes with doing individual teeth, if you're going to use those. With alveolar fractures, 26 gauge works very well also. You know, the arch bars are placed, and you've probably done these many times, and probably don't like doing this, but you can do them very efficiently if you get a system down between you and your assistant. The wires are passed outside of the gum tissue and tightened down on the top of the arch bars away from the lug. If you tighten them onto the lug, you can't use your lug, so this is important to have a clockwise twist that's in this area next to the lug. It's important also to use a bite block under jaw fracture circumstances. You can cause more damage to the temporomandibular joint and to the infraorbital nerve if you're not using a bite block. So please use a bite block, and don't leave your patients' follow-ups to themselves. You have to get them back in. Here's a patient who was missing for 4 years, finally came back in, and this is his arch bar. So it's an unfortunate circumstance, but early arch bars have some major hygiene issues, and so those certainly have to be looked at and can be contraindicated in many patients or poor follow-up. Placing IV loops is another way. Simple fractures, they're very easy to place. You can place them in the ED under local or topical anesthetic. An IV loop is made, so it's passed through the interdental space and brought around, and then brought through the loop and then tied down. You need 4 of these in order to have good fixation. This is an excellent thing to do to temporize patients who might have airway issues. Bridal wires, I use pretty extensively. You don't want to use them on the teeth in the fracture, but you want to try to use them on canines or something nearby where you pull the jaw together, and that can certainly help you put plates on too. So bridal wires are good for temporizing and they're good for intraoperative repair. IMF screws, I use a lot. I think they're great for temporary occlusion, and when fixing maxilla, in accordance with the rest of the bite, it's nice to have a temporary repair. The screws are generally put in the area of the unattached mucosa and between the roots. These will actually penetrate a tooth root and can cause the tooth to become non-vital. So you want to be really careful where you put these screws. I usually use the 12s in the maxilla and the 8s in the mandible. I generally don't make an incision when I put these in. I just do a slow job and they don't seem to tear the tissue. They're a wonderful way to treat these conditions. Here's a patient that was on helmet and motorcycle accident, has a ramus fracture, actually a huge, so condylar fracture, but it's a ramus fracture and a parasymphyseal body fracture. And we use IMF screws here for the occlusion, had to remove a tooth that was in the line of fracture, and the patient underwent repair, did very well. Okay. Other systems, the MMF system, there's Synthes has it, there are, Stryker has their system there, and they change fairly frequently. It's kind of hard to keep up with sometimes. Under certain circumstances, these are excellent ways to help get the patient into fixation, especially with the loss of dentition, or if they just cannot be wired together for reasons of fractures and of teeth and things like that, where you're not going to be able to have good fixation. These are a nice second system to use. I'm not sold on it. I've seen many of these come out. I've seen patients actually take these out. So you have to choose your patient pretty well to use these non-tooth bearing systems. Okay, I'm going to talk about a little bit about access. We have the intraoral approach and then extraoral approaches. The intraoral approach most commonly uses a labial sulcus incision, and this is very handy for any of the treatment of symphyseal and parasymphyseal fractures. You're away from the marginal mandibular, the mental nerve, and pretty much have excellent access with retraction of the lip. The vestibular, transoral vestibular incision is a real workhorse for us. The incision can be made along the necks of the teeth and reflect the gingiva and then sew these back, and that's actually a very good closure. I like this incision the best. Or you can make a vestibular incision with care taken to avoid the mental nerve. When you're making this incision and the mental nerve is found, it's important to open the soft tissue envelope around the nerve so that it can be mobilized. Otherwise, you can tear it with tension as it comes out. And then you can have both the superior and inferior access to the mandible around the nerve. So it's a nice view of preservation of the anterior, mid, and posterior labial branches of the mental nerve. You can proceed posteriorly, actually up the ramus, up the coronoid. This is a very nice access to the entire mandible from an intraoral aspect. And there's plenty of room to do good repair in this region. And here is an ankle fracture that's accessed in the same way. Transbuccal trocars, when your instrumentation angle is poor and you insert a transbuccal trocar, this is a ideal way to treat these areas. You want to just make sure that your plates are not off the edge of the inferior border, and that happens. Okay, as far as osteosynthesis goes, there's wire osteosynthesis that we've talked about and plate osteosynthesis, the issue comes down to load bearing and load sharing. And I'm going to talk about that in a minute. Cutaneous approaches into the external approaches to the mandible are through a variety of ways, certainly pre-auricular to the condyle and care taken to avoid the facial nerve. Transcutaneous retromandibular or Risdon approach is another way, and certainly you can approach the condyle this way with percutaneous repair using trocars, and sometimes you can do it without those, but this is an excellent access, and you're avoiding the facial nerve and the marginal mandibular nerve. The submandibular approach, excellent approach also, and it has potential of nerve injury here with the marginal mandibular nerve, but again, this is an excellent approach, and the scar is nicely hidden below the mandible. If you are concerned about injuring the marginal nerve, you can make a lower incision and certainly elevate it and get to that site. Submental transcutaneous. So these are all external approaches. Certainly intraoral approaches are less scarring. You get direct access to the bone. And this is usually the approach we use most of the time. Disadvantages, you do need assistance and you need some specialized equipment. You can't have limited access. Extraoral approaches can be open wide. They're easy to fix. And then you can hide the incisions, but you do get facial scarring, facial weakness, and these wounds can be contaminated and infected. The condylar fractures are certainly treated in many different ways. Most commonly are non-op. When we do operate, we'll use a transoral approach with a rainless incision and use the endoscopic equipment. External approaches I mentioned earlier are pre-ric and retromandibular. So the endoscopic approach it takes a little bit of time to develop, and we're good with endoscopes, so I would encourage you to utilize this. I'll show you something that we've used. It's this shadow line retractor. It's a cervical retractor for neurosurgery, and we had a cadaveric lab where we actually developed this, and we're trying to get actually better at this. But Dr. Scott Mann was involved with using this, and we've used it quite a bit now, but it gives you good access and it opens up a nice area. So you have the optical window, an optical space here that's fairly blood-free. Obviously in the cadaver it will be, but it's a big deal when you're treating somebody and retrieving the condyle. We actually did a percutaneous evaluation for the facial nerve and wrote this up regarding measuring 2 centimeters forward of the tragus to the lateral canthus of the eye on a horizontal plane. It's not really the Frankfurt horizontal, but it's from the canthus to the tragus. And then we measure out 2 centimeters and then down 2 centimeters perpendicular. And this is a really good spot to use a trocar. It's generally over the condyle, and it's generally between the 2 major branches, the orbital and buccal branches of the facial nerve. So these are just some things that you can use while treating these condyles endoscopically. The external fixators are not something we use often. They're certainly available and under special circumstances. It's important to note that when you are putting in a locking screw, you are actually creating an external-internal fixator or an internal-external fixation, because you are locking the screw into a plate much like you are locking a screw into an external fixator. This is contained internally, and the fixation is not plate against bone, but being held away from bone. This is actually, I believe, gives you a better occlusion. As far as edentulous fractures go, just to mention that there are many ways to treat these. In the older days, splints were used, dentures or gunning splints, biphase appliances like I was just shown as an external fixator, or open reduction. When we use open reduction technique, we have to use load-bearing plates. This is gunning splint. This is a denture made into a gunning splint. And when a patient can be operated on where rigid fixation is impossible, you can tap your prosthetic colleagues to help you design these splints where the patient can actually open his mouth, and you put these little hooks on the splints, they interdigitate, and the patient wears these and they eat through this small hole up front while their jaw is healing. The load-bearing issue is that if the bone doesn't have enough surface area in contact, you have to use a load-bearing plate with a bicortical screw and not the simple plates. These will not work on an edentulous fracture. So load-bearing is a big issue. You want to put the load on the plate. These plates will bend and the bone will not heal. So, and here is a case of an edentulous fracture showing a rigid plate. Okay, so we did talk a little bit about wires and a little bit about plates and the load bearing and load sharing. The wire osteosynthesis is still, I think, a good option. And I think that as residents, it's a good idea to hang on to some of these techniques. And these are figure of 8 wires. It's a little older. There are a lot of places in the world that still use wire. And then we use wire fairly commonly using early Garch bars. Plate osteosynthesis is really the best way to go right now. And it allows the patient to function sooner. And it has excellent repair for primary healing. Other thoughts are considering bone substitutes. We've, at our hospital, used this product. It's a bone putty, and under circumstances where we can't graft. This is an older woman with breast cancer, and she had an infected mandible, and we were able to clean the infection out in the dead bone, the osteolytic bone. This was not metastatic cancer, but it was bothering her for some time, and she received a bone plate and this bone morphogenic protein, and it worked very well. And there's a few other cases we've used it on very successfully. So for complications, we're going to kind of finalize this. The biggest issues are to prevent infections, to treat teeth in the line of fracture by extraction. Many people like to save these teeth, and time after time, these have become infected and cause non-healing wounds. So unless the tooth is totally needed and can help reduce your fracture, I would be inclined to remove teeth in the line of fractures. And most of the delayed healing and non-unions I've seen have had to do with infected teeth. Patients that are non-compliant many times end up with delayed union and non-union. These many times will require bone grafting. And I usually try to scare the patients a little bit when I think that they're not going to be compliant and discuss bone grafting early on. And somehow that psychology works or has worked to let them know that they're a partner in the treatment of their mandible. Malunion occurs when we don't get things back the way we want them, or we use a bone plate that is bent wrong and we create a malunion, and these are generally identified early and treated early. TMJ ankylosis occurs often when we don't treat the TMJ correctly in a head or neck fracture where you have hemarthrosis and ankylosis. So these have to be mobilized early, and many times with early arch bars using guiding elastics, and that's another topic for another time. Injury to nerves, the 5th nerve and the 7th nerve, we try to avoid at all cost. And placing our screws correctly with no heat, with water, and keeping things cool, placing them correctly. This is what we do as artists to make sure that our fixations don't fail. Certainly hygiene postoperatively, you know, saltwater rinses, Paradex, whatever. I'd like to keep people in MMF a little bit longer till their wounds heal, and I find I have a little bit better results. It may be difficult under certain circumstances, but to see a wound open up in an exposed plate is very painful. So many of our patients, we'll put them in IMF screws for a period of time, but we certainly counsel them and let them know that they're part of the team, and certainly hygiene and those issues are a big part of our game plan. That's all I have right now for this little interlude on mandibular fractures. I hope it meets your satisfaction. If it doesn't, you can always take a look at the resident guide for facial trauma that's available on the internet. Thanks. Have a nice day.
Thank you very much. That was a great lecture.
Thank you.
I have a quick question. Typically, we put a recon bar, usually do an external approach, but in that woman with breast cancer, it looked like you all did intraorally. Do you feel like you have pretty good access in the central portion to do that?
We can. Yeah, I think the translabial, the labial sulcus approach, you can go all the way back to the angle if you have to. I think that if there's an infection and you have to take out the sinus tract and some of that tissue, it's kind of a no-brainer. And I didn't mention it, but a lot of patients come in with big lacerations, and sometimes they're a blessing, especially mid-phase, because they give you wonderful access to pieces of bone that you can't really fit together. So I think I wouldn't shy away from open approach. I just be really careful of your nerves and your aesthetics. But yeah, she was, the bone morphogenic protein, we don't use that much, but under some of these circumstances, it's worked very well, especially with old delayed fractures that are non-union or malunion, and we re-break them and we add the bone morphogenic protein. We don't have to tap the hip anymore and take medullary bone. So it's a good way to treat them.
Yeah, what products are you using, like a Vivigen or the?
This product is, there are different products available to us. We have one that's a sponge, and then we put the liquid into it. I actually had a patient that exploded their mandible and the entire medullary space was gone. And we loaded it with these sponges and we added the bone morphogenic protein and closed it. And it worked very well. And then I asked for it again at another time, and then I got this substance. So, I'm not, proficient enough to say I like this or that, but both of these work very well. And so the concern I have, and our oral surgeons have, and we share the OR with them many times, is that the liquid form that goes into gel foam can leach out. This actually has a wax base to it, and so it's like a putty, and you put it on there, you close the wound as watertight as you can, and for some reason this protects itself and then slowly remodels. So I've been real impressed with it, and it's PROGENIX is the name of it, and it has the bone morphogenic protein and demineralized bone matrix inside of it with this biocompatible carrier. So under different circumstances, you could pick one or the other, and then however proficient you get with it. I just put my hand out and say, give me some bone morphogenic protein, and if I don't like it, I'll try something else. But we don't use it that often. It does cause a lot of swelling. The liquid form with the gel foam, I've had a few cases where the patient actually gets enormous swelling, and I tell them ahead of time that they can expect it. And I think it's a tissue reaction.
Well, thank you. Sorry, I think I missed that part, but I appreciate your talk.
You're welcome. This was fun. Appreciate it.
All right, take care.
You bet. Bye-bye.